Hello everyone, welcome to the progress report, and I would like to talk to you about the consequences of inappropriate antibiotic use in the intensive care unit. I'm Levente Prácser, I'm an anesthesiology resident, also an educator, and my vision is that I want to live in a world where every physician has access to the most up-to-date resources, and my mission is to provide physicians with these essential resources to make the best decisions possible. To date, I have two specific goals, first of which is investigating the effects of inappropriate antibiotic use on complication rate in the intensive care unit. We are approaching this problem with the method of systematic review and meta-analysis. What is inappropriate antibiotic use? Not every inappropriate antibiotic use is created equally. The easiest to understand is unnecessary antibiotic use, when we administer antibiotics when there is no bacterial infection. The other one, which is quite important, is incorrect dosing, because antibiotics require, based on their pharmacological properties, adequate concentration levels or higher peak concentrations, or both of them to be effective. And many factors can influence this, these levels, and we don't. Sometimes there is not readily reported whether they are penetrating the right tissue or not penetrating the right tissue. So it is also a factor we are trying to investigate. The too narrow spectrum inappropriateness means that the bacteria is not susceptible to the given antibiotic, and too broad spectrum means that we are overshot our reach and we are using way more aggressive treatments than is necessary. The problem is that antibiotic usage has increased globally in the past decades, and also this increased global usage is a high proportion of this inappropriate usage is high proportion of this usage is inappropriate in the ICU setting, ranging as high as over 40%. And if we look at the graph, we can see if we consider a constant growing trend, this problem is only going to increase. What we know is that guidelines, especially sepsis guidelines, recommend a very early antibiotic administration, which in real life leads to a large proportion of inappropriate antibiotic use, which can lead to complications such as the selection of multi-drug resistant infections. The missing link is that we don't know what consequences this inappropriate antibiotic use have. And our aim is to investigate these consequences. To answer this question, whether does inappropriate antibiotic use have an impact on complication rate in the critically ill, we are examining critically ill patients with suspected infection, and we are comparing inappropriate antibiotic use to appropriate antibiotic use, examining organ dysfunction parameters, multi-drug resistant infection occurrence, Clostridium difficile infection occurrence, and secondary outcomes, length of hospital and ICU stay, adverse events related to drug use, and mortality. And our hypothesis is that inappropriate antibiotic use increases complication rate in critically ill patients. We did our systematic search on 3 main databases using the search key seen on the board. The first domain is referring to the antibiotic use, the second one is the settings and the patient population, the critically ill, and the third one is referring to the appropriateness of the antibiotic use. We are in the middle of selecting we are in the middle of the title abstract selection phase, and preliminary we can see that around 1,300 articles will be eligible for full text selection. My selection partners are hard at work, and preliminarily we extracted a very specific subgroup of patients, which are patients with Acinetobacter bacteremia, and we are examining in this forest plot the mortality rate of Acinetobacter bacteremia patients, and the type of inappropriateness that you can see is too narrow spectrum. So, as you can see on the forest plot, first of all, I have to comment that the ICU and ICU plus ward, what does this mean? These are only settings. They are all critically ill patients, and they are all retrospective observational studies. The results, as you can see, is measured in odds ratio, and which is 1.31, 1 odds ratio means that there is no difference, so the exposed group and the unexposed group are the same. This means that there's a 30% increase in the inappropriate group in mortality compared to the appropriate use. But what is interesting in this graph is that the confidence interval overlaps the one line, meaning that the results are statistically not significant, although it can be clinically relevant. To draw further conclusions from this type of graph, due to the complexity of the problem, would be unwise at this stage. We are waiting for the other results to derive these conclusions. The other results we are analyzing are the ones that you can see on the board. The other outcomes are under analysis. So our first project is at this phase. Let's go on to my second project, which is procalcitonin kinetics guided antibiotic management in patients with septic shock. This is we are in the process of drafting the protocol of a randomized controlled trial. Sepsis-3 brought a new paradigm to sepsis management and sepsis definition. From now on, sepsis is defined as an infection plus an unregulated host response to this infection. The problem is that in this sepsis guideline, the recommendation is that immediate, ideally within 1 hour administration of antibiotics is recommended, which is a very strong recommendation, but with low level of evidence. This leads to the overuse of antibiotics, which can lead to adverse events. So our proposed solution to this problem is to guide this therapy using procalcitonin kinetics and the clinical progression. And our primary aim is to assess the effect of procalcitonin kinetics guided antibiotic therapy on the clinical course. Our question we are asking is, does procalcitonin kinetics based antibiotic management reduce antibiotic administration and improve outcomes in septic shock? We are examining lower severity septic shock patients. We must define what lower severity septic shock is. We had interdisciplinary meetings to define lower severity septic shock, and we arrived at a norepinephrine dose we are binding it to, and the lactate level between 2 to 4 millimoles per liter, because over 4 the mortality is significantly increased. We are comparing PCT kinetics guided antibiotic therapy to standard empiric therapy, and we are looking at organ dysfunction parameters, antibiotic appropriateness, length of ICU and hospital stay, and mortality. The clinical implication for this study is that by individualizing antibiotic treatment, we can reduce the unnecessary antibiotic usage and improve clinical outcomes. We are at the process of drafting the protocol. We will be planning to have more interdisciplinary meetings in the upcoming months. And to summarize, I have 2 projects ongoing, and to refer to the hardships we have experienced with the project, I would like to close with the quote of Theodore Roosevelt: "Nothing worth having comes easy." Thank you for your attention.
Thank you very much, Levente. Very nice topic, very nice clinical topic. My question is, comes for your second project. Regarding your protocol.
Yes.
Is it possible to use the absolute values of PCT in the control group? Because if yes, it means that maybe you will compare the absolute value guided therapy to the kinetic guided PCT therapy. What do you think about that?
This can be an approach. We have talked about it. We have discussed it, whether examining this would be a good idea. We have derived that dividing patients with surgical type infections to medical-like infections, we should use different thresholds for procalcitonin cutoff values. We are contacting international experts to define whether we are using dynamic or static ones. So far, the static parameters seem to be the winner ones.
Thank you very much.
I have actually 2 questions. The first one, how do you want to deal with that problem? You know, many patients get antibiotics by prophylaxis, for example, lung transplanted patients. Do you consider it inadequate antibiotic therapy? You know, because we are not treating with it any bacteria.
We are considering antibiotic therapy as there is a suspected infection. So in prophylaxis, we are not suspecting an infection. So it's a preventive measure. Mm-hmm. It's not considered treatment in that case.
So you just exclude it from your?
For this study, this purpose, yes. Mm-hmm. But it is an interesting idea for later examinations, yes.
Yeah, and my second question is, when you showed the forest plot, I was a little bit confused because you said it was about Acinetobacter bacteremia.
Yes.
And it was the, you know, the treatment was a too narrow spectrum.
Yes.
But in one case, it could be a carbapenem. In second case, it could be vancomycin, for example. The first one is a nephrotoxic agent. The second one, for example, ceftriaxone, it's a hepatotoxic patient. So how can you compare these?
That is a problem that we have to deal with. With meta-analysis, it's a bit harder because we are working with the data we've got. But in these data sets, if we examine from another aspect, if we are examining the two broad-spectrum antibiotic use, that could mitigate this problem you are having. Because what the main problem with this is that if we are considering antibiotic therapy to be good because the patient needs it, then the patient needs it, so there's nothing we can do as a preventive measure. We are looking at preventable complications and how these inappropriate antibiotic use affects these preventable measures. But you are right that not all antibiotics are created equal, but with the method of meta-analysis, these are really hard to distinguish. So it can be implication for future research.
Thank you very much.
Thank you very much for your presentation. I find it very exciting. I'm interested in, do you have any information or maybe an idea from your own clinical experience that which type of inappropriateness is most common?
It depends on the setting, the hospital ward, and the overall population in the region. So it varies widely. But what most commonly I see is that critically ill patients arrive and physicians generally overshoot. So they are prescribing more broader spectrum antibiotics than necessary in order to cover their bases. So and afterwards the de-escalation doesn't always happen.
See, thank you very much.
I would like to ask that for your second project, septic shock patient, it can be a really wide range from the really serious cases and maybe the milder ones. What kind of septic shock patients would you like to include in this study?
This raises an interesting other question that we must protect patients from harm. So we can't cause harm for these patients for the purpose of a study. But what we have seen in the literature, first of all, is the lactate level is one of the most strongly correlated with mortality. And if the patient is not solely evaluated on procalcitonin levels, it's also evaluated on clinical course levels. So if the patient is becoming unstable or is worsening, it's not no longer stable without antibiotics, then the patient will be excluded. But we haven't reached the drafting, the phase in the protocol drafting where this is established, who do we exclude and when.